good evening and good afternoon to our speakers, chairs, and audiences of ACNS webinars in different parts of the world. We are back again with yet another session of educational lectures for you. The first speaker for today is Professor Arthur Dalton from United Kingdom. He is a consultant neurosurgeon at the Charing Cross Hospital, Imperial College NHS Trust, UK. He completed his neurosurgical training from Newcastle, Middlesbrough, and Oxford, UK. He was a former fellow under Professor Ramesh Nair and Professor Mendoza, under whom he mastered skull base and vascular neurosurgery. His specialist interests include skull base and vascular neurosurgery, including the surgical treatment of trigeminal neuralgia and hemifacial spasm. He has been trained extensively in this field under giants like Fred Nath, Alistair Jenkins, Richard Kerr, Michael Cusumano, Ramesh Nair, and Professor Nigel Mendoza. We are extremely thankful to Professor Dalton for accepting our invitation to be a speaker at our webinars, and today is going to talk about trigeminal neuralgias. The second speaker for today is our honored guest from China, Professor Hong Tao. Professor Tao is the attending neurosurgeon and associate professor, Department of Neurosurgery, Suanwu Hospital, Capital Medical University, Beijing, China. Dr. Hong currently engages in neurovascular surgery and interventional treatment and specializes in open surgery of cerebral AVMs. He is a noted writer who has published several manuscripts in various peer-reviewed journals. He currently serves as the Youth Vice Chairman of the Neurointervention Branch of the Chinese Stroke Association, a member of the Chinese Federation of Interventional Neuroradiology of the Chinese Medical Doctors Association, and youth member of Chinese Neurosurgical Association. We are extremely thankful to Professor Hong Tao for accepting our invitation to be a speaker at our webinars. Today he is going to talk on resection of AVMs. The chair for the first session of today is Professor K.K. Turel, who is a consultant neurosurgeon at the Bombay Hospital, Mumbai, India. Professor Turel is a managing trustee, Mumbai Institute of Neurosciences. He also serves as the chairman, WFNS Committee on Complications in Neurosurgery. Professor Turel was the past president of the Neurological Society of India, Bombay Neurosciences Association, Academia Eurasiana Neurochirurgica, and Asia Oceanic Skull Base Society. Professor Turel just concluded one of the most wonderful online events in neurosurgery titled The Complications in Neurosurgery. We are extremely honored and thankful to Professor Turel for accepting our invitation to chair today's webinar. The second chair for today is one of the most famous hybrid surgeons of the world, Professor Xu Bin. Professor Bin is a consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. Professor Bin's practice include hybrid neurosurgery, and he has also the most number of bypass surgeries in the world for myomy disease. Professor Bin's contribution to ACNS webinars has been outstanding. We are very much indebted to him for that. We are extremely thankful to Professor Bin for accepting invitation to chair today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Liu Bun Seng from Malaysia is my co-host for today, and a special welcome to all the distinguished faculties, Professor Suresh Nair, and all other distinguished members of this profession who have joined us. With that introduction, I would like to hand over this platform to Professor K.K. Turel.
Thank you so much, Dr. Raja and Dr. Yoko and everybody for this wonderful occasion. I'm really honored to chair this session with a very eminent speaker, Dr. Arthur Dalton. This is a subject which has been close to my heart for the last 4 or 5 decades, I would say. Trigeminal neuralgia. First of all, most important thing is clinical presentation, and you need to be aware of the correct diagnosis, because you can have many different types of headaches and facial pains, and you need to be very sure that this is the patient that is having trigeminal neuralgia, which is a classical lancinating, shooting electric current-like pain located only to the divisions of the trigeminal nerve, not anywhere beyond and not anywhere in the neck. So it's very important to have the correct diagnosis. Many of these patients would go to a dental surgeon who invariably start treating the teeth and sometimes extract them. And quite a lot of times we have seen people coming without any teeth because of the dental treatment. So we need to educate our dentists also on this subject. Etiology in the vast majority of patients, as we may have known already, is in about 85% of patients is vascular compression by an artery, by a vein, or by both. But in about 15% of patients, there would also be a tumor or an AV malformation or an aneurysm, and sometimes multiple sclerosis. So these are some other causes. And because of this multiplicity of causes, it's very important to have an MRI of the patient much before you even start the treatment. Because if you are going to give some carbamazepine to a patient who's already having a CP angle tumor, you are treating something wrong. So anytime a person comes with trigeminal neuralgia, you need to have at least a good MRI. And there are some very specific MRI protocol, a trigeminal neuralgia protocol, which means that you need to do some good TOF MRA for arterial compression and some thin HI, high resolution T1 weighted post-contrast 3D imaging for seeing the veins. So these are extremely important MRI images that you must see. I'm again saying that you should not overlook venous etiology. And I was one of the first people to talk about this in the world many years ago, because I found several patients having venous compression. When you are operating, it's very important. First of all, yes, medical treatment is the first treatment of choice. Carbamazepine works in the vast majority, at least at the beginning. But when it doesn't work, then you need to consider other procedures. There are ablative procedures such as things like chemical rhizotomy. You inject alcohol or glycerol. Nobody injects alcohol now. Or you can do RFTC, thermal injury, balloon compression, or finally gamma knife, depending on what the choice of the surgeon and the choice of the patient is. And you would only offer these kind of treatment if the patient is unwilling for surgery or he is unhealthy or unfit for surgery. By and large, most of the patients would benefit by a good surgical procedure, and that procedure is called microvascular decompression, which is done by a very carefully correct diagnosis of the patient, first of all. Then you must have the optimization of the procedure, and then identification of the neurovascular conflict and management of this conflict. So the correct positioning of the patient whilst they're operating, I'm sure Dr. Dalton will tell us all about that. And then how to not sacrifice any veins, petrosal vein particularly. Many people they sacrifice the petrosal vein if it is coming in the way. I would say do not try to sacrifice any veins. Try to preserve them as much as you can in order to have good results of microvascular decompression and with zero morbidity and mortality. So correct diagnosis, optimization of the procedure, and identification of the vascular compression structures, very important. MBD has great advantages because it gives you instant relief. Complications are extremely rare when it is done by an expert hand, and side effects are such as neuropathic pain are unknown with MBD procedure, though they may be occurring with other ablative procedures. I use Teflon in almost all the patients, and very minimal cerebral retraction just at the beginning. And once the brain shrinks and the CSF comes out, then you don't need retraction. And then do not make the common mistake of attacking the 7th and the 8th now, because that's the first thing that you will see during your exposure. And trigeminal nerve is much deeper in a lower compartment. So look out for the trigeminal nerve, and then visualize the entire nerve from the brainstem all the way to the Meckel's nerve, all the way to the Meckel's cave. Remember that you may have a vascular compression, not necessarily every time at the brainstem. And then you may have a vascular, once you identified a vascular compression, do not celebrate, you may have more than one vessel. So look out all 360 degrees. And sometimes it is difficult to see under a microscope, in which case an endoscope may be of additional advantage. And interposition or transposition of the offending vessel is left to the surgeon's choice, whatever he prefers to do. And we should be expecting to have a very good disposition on the subject by Professor Dalton. I'm not touching the subject of recurrent trigeminal neuralgia because that's quite another matter, but we will see during the course of discussion whether we need to talk about it or not. So I think with this brief introduction, I would now pass on this screen to my friend Arthur Dalton. Thank you very much.
Thank you very much, Professor Terrell. That's appreciate your kind words in introduction, and also your pearls and your wisdom. So yes, it is an absolute delight and pleasure to be presenting to you all today. I'm very grateful for the kind invitation. I'm going to be talking on the subject of trigeminal neuralgia. What is it and how can it be treated? I have included Nigel Mendoza's name in this presentation since he's contributed a lot to it, and I feature some of his results and results of Risto Ramesh Nair. We work at Charing Cross Hospital, which is shown bottom right, and also St Mary's Hospital, both of which are affiliated with Imperial College University in London. And my overarching aims when preparing this presentation was that I was hoping to keep the content of it relevant to us all as clinicians, And I hope to share with you some of the pearls and pitfalls that have been passed on to me through my training and my mentors, and make some of these the key messages of my presentation. And above all, I just hope that this presentation is useful to surgeons training in this field, and perhaps those who are hoping to stay up to date. I will, of course, have to touch on some of the important aspects of the condition, such as the pathophysiology, the diagnosis and management, and the updated evidence and evidence base behind these decisions and classifications. I'll start with this nice paper from a group in Italy, which highlights the problem of recognition and management of trigeminal neuralgia, which I'm sure you're all very familiar with. We say in England that patients often get passed from pillar to post because they're managed by a wide variety of different practitioners, family doctors, GPs, dentists, ENT surgeons, neurologists, neurosurgeons. And in this paper, they present 100 patients consecutively enrolled, and they found that 50% of them, half of them, were misdiagnosed initially. And that on average, from first presentation to diagnosis was approximately 1 year. And they had estimated a diagnostic delay of 7 months and 18 months. And why is this? Well, fundamentally, it's because trigeminal neuralgia is a rare condition. Facial pain is common, but trigeminal neuralgia is rare, and it represents the tip of the iceberg in the concept of orofacial pain. And also because of the fact that in most centers, there is not this very well-organized, concentrated, team-based approach with early referral to a joint specialist center. So what are the differential diagnoses? Well, I think by far and away the most common causes of orofacial pain, temporomandibular joint disorders, myofascial pain, and dysfunction disorders. A lot of patients ended up and labeled as atypical facial pain, which can be a bit of a waste paper basket catch-all diagnosis. And there are a lot of other neurological causes for headaches, such as cluster headaches, migrainous neuralgias, short-lasting unilateral neuralgia form headaches with conjunctival injection and tearing, other compressive cranial neuropathies such as glossopharyngeal neuralgia, which can mimic trigeminal neuralgia, and also trigeminal neuropathies resulting from a wide variety of causes such as post-infective, trauma, etc., etc. And unfortunately, it's not a spot diagnosis, although casual observation of your patient can sometimes give you useful pointers, hence this slide I include here. Munch's subject and this gentleman up here on the right, they're clearly holding both sides of their head, which goes against the diagnosis of trigeminal neuralgia, which by definition is unilateral. And a lot of these people seeming to be really pushing into their faces, pressing hard, massaging their faces. And that really goes against the diagnosis of trigeminal neuralgia, where most people are afraid to touch their face even because innocuous stimuli are triggering the pain. And whilst it's not absolutely impossible, it is very unusual to have trigeminal neuralgia in very young people and children. Most of the presentation is in mid to late middle age. And the clinical features, as Professor Terrell has mentioned already, I really think the hallmark clinical feature is recurrent episodes or recurrent paroxysms of severe unilateral pain of short duration that respects the trigeminal nerve dermatome. And what does short duration mean? Well, it means abrupt onset and offset, typically a fraction of a second, like lightning, being electrocuted, or having an ice pick in your face. The recent classifications and definitions say it's either a fraction of a second or up to 2 minutes. It typically has associated trigger points of the skin where just the slightest stimulation can trigger and reproduce the pain. It can come and go in a quirky manner. You can have periods of remission where all your symptoms disappear and you cannot provoke the pain, and then it can come and go as it will. The typical distribution is most commonly in the maxillary and the mandibular divisions, and the most typical trigger point would be the nasolabial fold. And although the precise pattern and precise nature of symptoms might vary from patient to patient, they are very stereotyped for each patient. And each patient can give you a very clear, specific description of their symptoms. If a patient is presenting to rather vague story, they can't really give you any accurate details, then that's clearly not trigeminal neuralgia. Most patients with trigeminal neuralgia can even remember where they were when they first suffered the pain. And importantly, clinical examination should be pretty normal. If you try very hard, you can find subtle sensory abnormalities in the trigeminal nerve, and experimental studies will almost always find subclinical sensory disturbances. But if you've got a very marked sensory disturbance, or indeed if you have some other cranial nerve problems, an abnormal examination, then actually it calls into question the diagnosis of the classic typical trigeminal neuralgia and points to another underlying secondary cause. But the precise nature of the clinical features has varied a little bit and evolved a little bit as people's understanding and experience of the condition has changed. What about constant background burning or dull pain? I've always been trained to think of this as rather atypical sounding, and many people would consider this a progression of the disease to a more atypical or treatment-resistant form. Actually, in some of the updated classifications, the thinking about this seems to be changing. And provided you have a predominant feature of the paroxysmal lancinating pain, then you are allowed, in inverted commas, to have a background constant dull ache throbbing pain. And the recent classifications would tend to subdivide the classic trigeminal neuralgia syndrome into those who have additional background pain and those who do not have any background pain. And also, you might notice that some patients have mild autonomic features associated with their symptoms. But again, it shouldn't really be a very prominent or dominant feature of their syndrome. European population-based studies place the prevalence of the condition at 0.1 to 0.3%. So it is a rare condition. It is more common in women than it is in men. And the average age of onset is in the mid to late 50s. There has been some evolving work on the genetics, and particularly in familial clustering cases of trigeminal neuralgia, they've seen some gain of function mutations in voltage-gated sodium channels. And so it's speculated that perhaps there is a genetic component and might play more of a significant role in purely idiopathic forms of trigeminal neuralgia. And what about the natural history? What's going to happen to a patient if we just observe them and if we just treat them medically? What about the timing of surgery? When should we offer us surgery? Well, what we know for certain is that there are no lack of class 1 evidence on the natural history. What we think we know, or maybe I should even say what we thought we know, are that the disease progresses with increasing severity of symptoms, in decreasing intervals of remission, the pain becomes more constant and atypical and perhaps even more treatment resistant. And certainly I think that was the way I was trained and taught to think of the illness, but actually that is being challenged with some of the recent work and studies in the literature. And what causes it? Well, the commonly held hypothesis now has actually got quite good evidence behind it from biopsy studies, looking at biopsy specimens from trigeminal neuralgia sufferers, looking at advanced imaging studies with diffusion tensor tractography, and also with electrophysiological studies. And they all point to pathology being at the dorsal root entry zone, where any good medical student will be able to tell you we have the zone of transition from peripheral myelin to central myelin. And on the biopsies, they see demyelination and dysmyelination and remyelination. And on the electrophysiological tests, they see excitability and they see delayed conduction and delayed transmission of nociceptive blink reflexes and pain-related evoked potentials. And the apposition, the direct apposition of demyelinated axons intuitively fits with this paroxysmal lancinating pain. A beta fibers, which are typically myelinated and convey light touch, directly opposed and synapsing abnormally with a delta fibers conveying fast pain, can fit with this explosive lancinating pain to the slightest touch or innocuous stimuli. However, there's also evolving recognition of a process of central sensitization. And this essentially means either upregulation of the ending second neurons in the pathway and the plasticity of the networks that are experiencing of pain, and also loss of the inhibitory pathways coming down from the supratentorial regions. And actually, when you look at the pain-related evoked potentials, if you compare healthy people with trigeminal nerve sufferers, you see delays to transmission of these impulses. If you look at patients with trigeminal neuralgia who either have pure paroxysmal pain or patients who have trigeminal neuralgia with constant background pain, then you see something interesting. You actually see a speeding up of transmission and a larger amplitude of response to these evoked potentials in patients who have the constant background pain, which would actually support this notion that it's a process of central sensitization which is contributing to this background pain, as opposed to progression and worsening of the primary pathology in the dorsal root entry zone. And so the classifications have evolved with time, and two organizations which spearhead this would be the International Association for Study of Pain and also the International Headache Society, which performs its classification of headache disorders, of which we're now in the 3rd edition. And of course, there are notorious research groups who have proffered various classification systems. Helpfully, the updated classifications in the last 2 or 3 years have unified really the IASP and the Headache Society. They've unified their definitions and classifications, which is helpful, and probably simplified them somewhat. And I'll just describe them there. We have classic trigeminal neuralgia first, which, I'm sorry, I should say all of these are diagnosed on the history. So all these 3 groups have the key feature being the paroxysmal pain, and subgroups is made up on MRI analysis. So as Professor Terrell says, an MRI scan is essential. So we have classic trigeminal neuralgia group, first of all, which is both the classic symptoms, but also an MRI scan demonstrating neurovascular compression. And the key thing they stress is that the MRI scan must show morphological change to the root entry zone. You must see either atrophy of the nerve root or distortion or displacement of its course. And in the second group, we have neuralgia, where in addition to the classic symptoms, you have MRI evidence of an alternative pathology, such as plaques of demyelination, such as multiple sclerosis, or you have tumors and such like. And then in the third group, which they call idiopathic trigeminal neuralgia, you have patients with a normal MRI scan. But also interestingly to note in this classification is that they say a normal MRI scan is one where there is no morphological change to the nerve root. So if you have a scan which shows a loop, an artery or a vein in contact with the root entry zone, then that's considered a normal variant if there is no morphological change, there's no distortion to that nerve. I think that's actually a difference during my training, and I'll touch on that a little bit later. So to summarize, the diagnosis is on the history, the MRI is for confirmation of the subtype, and actually concomitant constant background pain is used to sub-classify those patients with neuralgia with or without concomitant background pain. And this is an MRI scan which shows neurovascular compression on the right side with morphological change. You can see the nerve is indented and slightly distorted and thinned at the root entry zone. And this is a patient with classic symptoms who did well from surgery. This is a patient, a young man who, in addition to their classic symptoms of trigeminal neuralgia, had deafness on one side. So straight away, you're assuming to look for an alternative pathology, as he had demonstrated here. And this is a scan of a youngish patient who had 3 years history of classic trigeminal neuralgia and absolutely nothing else. Here you see an abnormal lesion, most likely an epidermoid lesion responsible. And so what do we do if the patient cannot have an MRI scan? Well, the next best thing is probably electrophysiological testing of trigeminal nerve reflexes, which has been shown to be somewhat discriminatory in patients with and the first line treatment, as with most neurosurgical procedures, is to try more conservative options first. They're generally safest, so medical options first. And there's now some evidence to suggest that carbamazepine and oxcarbazepine, these anti-convulsant drugs, are the preferred first-line medicines. Pregabalin, gabapentin, or triptyline, amitriptyline, baclofen, a whole host of other medications that can be tried as add-on or standalone therapies in second line. And don't forget, for very severe acute exacerbations, so patients who come in needing to be hospitalized because they're so debilitated by the frequency of their attacks, in addition to urgent surgery, which could be considered ligdocaine. And these have been shown to be pretty effective as well, but they do require some specialist input and experience and some close monitoring, usually in some form of high dependency setting. And what about the surgical options? Generally speaking, we think of the surgical options when medical management isn't working, the side effects are intolerable, or if actually it's patient choice, an informed choice to go with surgery. Peripheral neurectomy is a largely outdated procedure. I have to say I have no experience of and we don't use. Stereotactic radiosurgery is really surgery only in name, but it is a very useful treatment, and I include it in the list and I shall touch on it later. Deep brain stimulation is very rarely done for select cases. So really the mainstay is, as Professor Terrell said, microvascular decompression and also percutaneous rhizotomy procedures, of which which all have the same effect of bringing about damage to the Gasserian ganglion in Meckel's cave, either with chemical means with injection of glycerol, thermal means with radiofrequency ablation, or mechanical means with balloon compression. And we would say they're all much of a muchness. The literature would suggest that there isn't any real evidence to demonstrate the superiority of any one of these over the others, and you can really take your pick. Microvascular decompression, which I think most surgeons who manage this condition will be strong proponents of and will say is a delightful operation. The key advantages of microvascular decompression are that it tends to be a definitive procedure. It does have a high rate of long-term success in well-selected patients, and it brings about a very rapid response, early withdrawal of medications, and a lot of patients are very grateful and delighted to have undergone the procedure. The disadvantages are that it is major brain surgery. Complications are rare, but they are very serious if they do occur. It's contraindicated or difficult in patients with significant comorbidities and advanced age. It does require specialist experience, and there is evidence to suggest that when performed in a high volume center, length of stay is better and outcomes are better. And of course, any major surgical procedure opens you up to some risks of litigation. And so we have to consider a trade-off between going for a nice, simple, straightforward procedure and a procedure with a better chance of a long-term cure for the patient. So microvascular decompression would tend to be done by a retrosigmoid craniotomy in a standard open microsurgical technique. It's quite often augmented with an endoscopic assisted procedure where you can use an endoscope to get better visualization and maybe to reduce the size of your approach. Really, there isn't a great deal of evidence to suggest the superiority of one technique. Like Professor Terrell said, the importance of position, supine position with a head turn and a table tilt are all valid techniques and all effective when done appropriately. The key position really is to prevent venous engorgement, to help with brain relaxation, and to ensure you've got the head turned sufficiently so that the petrous bone, the face of the petrous bone, is quite perpendicular to the floor. So you're not having to crane your neck and bring the microscope down to really look into the CP, into the cerebellopontine angle. And of course, positioning of your craniotomy is very important. Most surgeons would want to be able to see the junction of the transverse and sigmoid sinuses. They want to be able to see the back edge of the sinus, just so that they know that they don't have any overhangs of bone, which again would mean you're going to really struggle to get your microscopic view into the angle. You can do a very small craniotomy. Many surgeons have good success with that. You can do a larger craniotomy with to get you easy access into the cisterna magna. I think the key thing really is to ensure you've got good relaxation of the brain, and you can achieve this either by CSF release during your craniotomy or with CSF release at induction of anesthesia. I think in a younger patient or a patient with a full brain, not much atrophy, then it might be quite a nice idea to try CSF release at induction of anesthesia to help you get nice relaxation of the brain. And of course, don't forget clear communication with your anesthetist to ensure that you've got optimal anesthetic conditions to help with brain relaxation. And ultimately, on the size of craniotomy, it's a trade-off. The smaller your craniotomy, you begin to get diminishing returns, and actually the awkwardness or the problems you could run into could then start to put the risk of the patient back up again. And as for the angle of approach, well, I think we need to head for this angle that you see between the tentorial dura and the petrous dura. And right in this angle, we do see the vein of Dandy, the Dandy's veins, which you can see from this image. In this case, we have actually cut and taken. Now, this is an important point to note. Most surgeons would prefer to try and keep this intact, and that is my preference also. Whilst I have worked under I have worked under surgeons, many of whom have invariably taken this vein without any problems. We're all too familiar of the small number of reports of devastating problems with taking this vein. So I think it is preferable to try and preserve this vein. One also has to weigh up the potential risks of avulsing the vein. If you're very hampered by it, if you really can't get to the trigeminal nerve, or you can't manipulate the offending vessel conveniently or safely because of the veins, then you're also at risk of avulsing them, which can be a problem. So I think sometimes you do have to make a decision whether to actually take it in a controlled manner to reduce the risk of avulsing it later. And again, if you approach for that angle of the dura, then you will tend to come across the trigeminal nerve first of all. If your approach to the cerebellopontine angle and you're drifting inferiorly and you're just looking towards the petrous face, then you are more likely to come across the facial nerve first. And one thing that I've been taught is that the facial nerve, as well as being much more superficial and lateral and superficial in your exposure, it tends to be exiting the brainstem in a more perpendicular position, and often has this appearance of being more freely floating in the cerebellopontine angle system, and have greater space all around it. Whereas the trigeminal nerve tends to be a little bit more exiting the brainstem in a little bit more of a shallow oblique angle with less space all around it. So this is just a short video just to show dissecting of this arterial loop away from the dorsal root entry zone, and then interposing a little piece of Teflon, some Teflon fibers. You can also have Teflon wafers. And an alternative strategy is to glue the arterial loop to some of the adjacent dura and to anchor it away, so to transpose it away. What of the results? Microvascular decompression does tend to have a good, favorable outcome in the right hands and in the right patients. Immediate, these are sort of figures really from the literature. Immediate complete remission in as many as 90 or 95% of patients. And it does tend to drop off over time. And at 1 year, 85%, 80 to 85% in complete remission. And at 10 years, this has fallen to 70%. Patients with a poor result early on in all comers tends to be 2% of patients. People at 10 years with a poor result, so aggravation of symptoms or no improvement, around about a quarter of patients. Morbidity and mortality is very low. Mortality is very low, hovering at less than 1%. And serious complications such as hemorrhage, meningitis, facial weakness, deafness, wound infection, all hovering around about the 1%, 2%, 3% mark. Facial numbness or hyperesthesia are a little bit more common in up to 10% of patients. Over the period between 1995 and 2020, 250 MVD procedures taken. And this is largely the work of Nadia Mendoza and Ramesh Nair, and contributed in the latter years by myself. Finding that looking at all comers undergoing all comers undergoing MVD, the percentage of patients who are pain-free is drifting down from down to between 70 and 80% over 6 years. And when we look at patients who have definite compression and distortion of the nerve, clearly visible at the time of surgery, so that's the red line, then the results were much better. And when you had patients where the compression was a little bit indefinite, maybe there was a vein or a closely applied artery, but nothing we could really say very convincing as compression, and percutaneous rhizotomy being an alternative to surgery, our procedure of choice tends to be glycerol injection, but they're all very similar. The standard anatomical landmarks, the entry point being 2 centimeters lateral to the corner of the mouth, heading for an imaginary point in the mid-pupillary line, 3 centimeters anterior to the tragus. And a gloved finger inside the mouth can help ensure that you don't buttonhole the oral mucosa with the tip of your needle, and can also help you feel for a clench in the jaw as your muscles tighten as you enter the Gasserian ganglion. And we use X-ray image intensifier to and injection of dye to help us confirm that we're in Meckel's cave. We sit the patient up and we inject the anhydrous glycerol to bring about the chemical damage. And 585 procedures done in the same period, 15% of patients having repeat injections, 60% of whom were pain-free at 5 years, 10% having facial numbness, and significant complications pretty rare. These were the results at Imperial, broadly in line with that of the literature. And of course, we use stereotactic radiosurgery also, and essentially that involves applying a rigid frame to the patient's head and acquiring high-resolution MRI images wearing said frame, and calculating your coordinates to establish dorsal root entry zone, and plotting your conformal dose of radiation and then delivering it. And the key thing with stereotactic radiosurgery is that it does bring about pain relief, but after a latency period of anything between 1 and 13 months. And our results was, the mean period was 3 months before you got your pain relief. Early remission was present in about 90% of patients, and remission, persistent remission at 10 years drops off significantly to around about half patients. Mortality is obviously, well, pretty much zero with this very safe procedure, and sensory neuropathy being the most common long-term side effect. 5% after the first treatment and 32%, so rising with second or third treatments. So the decision-making that I basically developed throughout my training had been start with the history, see if the patient has the classic symptoms of trigeminal neuralgia. And if they do, you're going to investigate them further. You're going to do an MRI scan. If they don't have the classic symptoms, then think about the alternative diagnosis and consider referring them onwards to neurologists or maxillofacial surgeons or ENT surgeons. If your patient has the typical history and their scan shows a neurovascular compression, but is otherwise normal, then offer MVD first if they're medically fit for it. And if they're not, consider the stereotactic radiosurgery procedure or the rhizolysis procedures. Ultimately, you go with the choice of the patient once you've counseled them appropriately. And actually, all options really are on the table. But I must confess, really, in my training, I would tend to consider presence of close apposition of an arterial loop, usually sufficient grounds to offer this MVD as a first-line treatment. But potentially that is something which is recommending, the recommendation for that is changing in the literature. If the scan shows no neurovascular compression, then obviously you're going to consider other options ahead of MVD. But ultimately, MVD is still sometimes offered, and typically counseling the patients, there is a lower chance of success if you're offering an MVD procedure. Perhaps it's a more last resort when there are no evidence of neurovascular compression. But as I said, the actual guidance in the literature is beginning to evolve and has evolved over the years. And probably the most recent guideline policy document currently in publication is from the European Academy of Neurology, their guideline on trigeminal neuralgia. And the key thing to hold in mind is that this recommendation is on the basis of this most updated classification, whereby you have classic trigeminal neuralgia, meaning you have the classic symptoms, but you also have compression from a vascular loop with distortion and morphological change in the nerve root. And you have idiopathic trigeminal neuralgia, where you have the classic symptoms, but you have no morphological change in the nerve root. And they still recommend, as in line with most people's practice, first-line treatment being medical with carbamazepine, oxcarbazepine, and they would recommend surgical treatments if the symptoms are not adequately controlled. Again, in line with most people's practice. If you have classic trigeminal neuralgia, they would recommend MVD as the first-line treatment. If you have idiopathic trigeminal neuralgia, and so even if you have a contact with a neurovascular, even if you do have neurovascular contact with a vessel, but no actual morphological change, then they would suggest that all options are equally effective and equally recommended, and you can go with the choice of your patient. So in terms of future considerations, then the first thing to say really is that this new classification definitely needs road testing. It needs to be tested and audited, really. We need to look at the long-term outcomes according to the revised patient subgroups. Do patients who have idiopathic trigeminal neuralgia, they have a vessel in contact but no morphological change? What is their outcome following MVT, and how different is that to those who have the morphological change? And it would be nice to have prospective natural history studies to give us greater understanding of when we should be offering surgery. And then, of course, the exotic and exciting areas of machine learning and advanced imaging. There is some early work that looks quite interesting in this regard, where machine learning can identify trigeminal neuralgia sufferers with an accuracy of 88%, and also evolving abilities in predicting surgical non-responders according to various morphological problems within the brain. And so I want to just bring your attention to a few interesting articles out there. The first is from the well-known Dutch group, who have gone some way into road testing this new updated classification. And they've done a very nicely well-designed study to eliminate bias using independent assessors and not the surgeons themselves in assessing the quality of outcome following microvascular decompression. And also the other nice thing about this group is that they do have a very joined up, centralized, multi-specialist team-based approach with early. Well, they enrolled 360 odd patients with trigeminal neuralgia, most of whom they were able to manage medically, and only 72% of whom underwent microvascular decompression. They looked very carefully to ensure that they classified each of their patients according to the updated classifications. And they used multiple logistical regression models to try and really drill down and look at the effects of the various subclassifications on the outcomes to microvascular decompression. And what they found that was quite interesting was that men were much more likely to have an excellent result following microvascular decompression, with quite an impressive odds ratio there. And that if you had classic trigeminal neuralgia, as defined by definite morphological change in the nerve root, you were more likely to have an excellent result versus if you had no morphological change to your nerve root. So they looked at, so they found 94% of men who had the classic trigeminal neuralgia had an excellent result versus 71% of women. 89% of men who had the trigeminal neuralgia, so no actual morphological compression to their nerve root. A lot of them still had an excellent result at MVD. However, fewer women had an excellent result to MVD in this category. And they also looked to see whether or not having presence or absence of constant background pain affected the outcome. And they report that it had no effect at all on their outcomes from microvascular decompression. And if the symptoms had been present for a long time, duration of symptoms beyond 2 years prior to surgery, they did not notice that they reported that that had no effect on the long-term outcome. So I think this is quite a useful study, and definitely more information is needed in this regard to really look at the usefulness of this classification. Some other interesting papers. These two are both small studies coming out of Canada. The first is in 31 patients. They looked at abnormalities in diffuse or tensor imaging in the pontine trigeminal regions. And when present, this was typically associated with a poor response to surgery in 86% of patients. And then another one, which is even more interesting really, is looking at morphology of the thalamus and the hippocampus, even on the contralateral side to the trigeminal neuralgia. And they found that there was enlargement of the thalamus and the hippocampus, which accurately predicted non-responders to microvascular decompression. So both these are small studies, early studies, but definitely something to watch in the future. So as our trigeminal neuralgia is based on the history of paroxysmal and lancinating pain, having concomitant background, dull burning pain or throbbing pain may not necessarily be associated with poorer outcome. Audit of outcomes according to the latest classifications, and ideally through the use of registries, I think is needed. And I think probably concentrating care into joint specialist teams is likely going to be the preferred approach. So I'd just like to say a great thank you for inviting me to your presentation, and I'm very happy to be contacted in the future for questions or collaborations.
Unmute yourself, Professor Tura. Can you unmute? Press unmute. Yeah. Yes, Professor Ture.
So I have already answered 4 of these questions that were already put on the chat. On behalf of Arthur, I've taken the liberty to answer them. And I think these questions were concerning what would you do if your MRI is negative? Would you still consider MBD? That was one of the questions. And what would you do if you find a vein? Would you still do an MBD operation, or what would you? And the third thing is, what I mentioned is that if your MRI appears to be normal, you go back to the MRI department, to the specialist, and make a special effort to see that you've done very thin, high resolution T1 weighted post contrast images, 3D sequences, because that is the best way to pick up veins, and you don't see a artery or a distortion. There's a possibility that there might still be a vein. Arthur already spoke about the question, when you don't see a scan, would you still operate? Yes, if the history is classical, then we would consider surgery, but must take patient's consent for the possibility of not finding a vessel, in which case you may do a partial sensory rhizotomy in order to provide relief. This is something which I would definitely do in the patients who come with recurrent trigeminal after procedures. So, but I have, I have done more than 1,084 cases by now. And only one time I found a complete negative exploration. So this speaks of the high possibility of MBD, of neurovascular conflict being there, provided your history is correct. That's very important, that you must have a classical history of trigeminal neuralgia. And if the veins are there, most of the time you will be performing the same kind of MBD procedure. Occasionally the veins are traversing between the rootlets, in which case it may be difficult to do an MBD. And this is usually a small tributaries which can be safely transected, coagulated and transected. There is no scope of MBD in such cases. So that would be my answer. Yes. And if you still feel that you are not, during your exploration, you see that you are not able to identify a neurovascular conflict, take an endoscope and go all around. You are more likely to have missed something by under standard microscopic visualization. So an endoscope can be very useful, especially when you have a very large Peters bone projecting onto the, and making the CP angle extremely narrow. There might be a vein tucked underneath, and you may require to drill that area in order to identify the compression. So this is another trick that you may have to use. Sometimes you have an extremely narrow CP angle and very little space between the root entry zone and the Meckel's cave. I don't know if there are any more questions, but I'm sure we can have a short discussion if time permits.
So my one question to Mr. Dalton and other to Keiki. Keiki, you told that that you will do a rhizotomy in the event you don't see offending vessel, especially if it is a recurrent trigeminal neuralgia. No, instead of that, say you don't have to do a rhizotomy. You have to just squeeze the nerve with a bipolar force. That is as good as a rhizotomy. You don't have to do. So what we call kissing the nerve with a bipolar force. Just pressing, no current there. And then also I am very fascinated with Mr. Dalton's one publication. He showed that 31% of female patients with idiopathic trigeminal neuralgia, where there is a vessel there, no morphological change, they only responded as opposed to nearly 79% of males. So in female patients, why they don't behave well with surgery? I am very curious about that. In idiopathic trigeminal neuralgia, which you stated, where there is no morphological change, but you see a vessel there which is not producing any atrophy or displacement, they don't respond to surgery, while males respond. Females, they don't respond. So this is one question to Mr. Dalton. Also, what I want to add before I go out, there is one absolute contraindication for a classical idiopathic or whatever our classical trigeminal neuralgia is, if patient has a contralateral deafness and if patient has a dip in hearing on the affected side, then one should refrain from doing this procedure. Rather go to one of the percutaneous procedures. And also, I had the occasion to see one case of trigeminal neuralgia from a persistent trigeminal artery. So comments from both Mr. Dalton and from Mr. Keiki regarding is rhizotomy may not be the answer for recurrent, maybe just kissing the nerve. Please.
Well, thank you very much. Well, on the question of rhizotomy, then I'm nearer the start of my career to my esteemed colleagues present in this platform. And I have limited experience because it's not all that common. I think you're in this scenario. I think the important thing is to make sure that you've had a discussion with your patients before you've started about what you might do if you don't find any compression or any significant compression. And a lot depends really on patients, their age, what are the things, what are the treatments they've tried, how desperate they are, if they're recurrent trigeminal neuralgia or not. And obviously, an older patient who's gone around the houses and tried everything and they're really looking to you as the surgeon, they're often a bit more prepared to undertake a more aggressive rhizotomy procedure at the time of surgery. And that would be my sort of principle and philosophy. I have to say that the rare occasions that I have actually done it personally, I have used the kissing technique as well, using a bit of a pinch, a bit of rough handling with some bipolar forceps. That just intuitively to me seems to be a slightly less risky, more favorable procedure. But I'm sure the truth is no one really has any good quality, accurate evidence to tell us exactly what the best technique is. So that's my answer to that element of the question. To the second part of your question about the difference in men and women, well, I really have no actual opinion on this because this isn't my work. This is my just presenting to you an interesting paper I came across, which does appear to be in a very well designed study by an esteemed group and quite good methodology. So I think good credence can be inferred, and also it's interesting enough to warrant further study and looking at it. And just to be very clear, the biggest difference between men and women was in the class of idiopathic. So people with a very classic history, but with no definite compression radiologically with morphological change on the nerve roots. And it was quite a marked difference between men and women. And in their discussion, they don't really have a good explanation for it. And it's just something which I think, first of all, needs to be tested again to see if the truth is borne out in repeat study and repeat testing, which is why I just think it's useful for collectively us all to maybe, even if we don't absolutely believe in the new guideline and classification, to try it out and to test it and to make sure that we've recorded our patient outcomes according to this new classification.
Can I make one very quick comment since we know Dr. Dalton from UK? 30 years ago, we had Robin Sengupta visiting us. You must be knowing Robin Sengupta from Newcastle. And he was visiting us in Mumbai. And I was taking him on my ward round. And I showed him one patient of basilar ectasia that I had operated. And the patient was still in the wards. I said, this is a gentleman with a huge basilar artery ectasia, and I've decompressed. He said, oh my God, we are shocked. In Britain, if we make a diagnosis of basilar ectasia, we are not permitted to operate on this patient and no MBD allowed. I said, why? He says, because in our British meeting some years ago, a gentleman called Christopher Lai presented 3 mortalities after he attempted decompression on a patient with basilar ectasia. And the British Society took a decision, a unanimous decision, that no basilar ectasia will get a MBD operation because in your attempt to try and mobilize, you might overstretch the perforators and you might produce brainstem infarct or death. So that was the reason. I don't know what is the situation today in Britain, in UK.
Oh, I wouldn't necessarily believe that it's as stark and black and white, and you're going to be, executed by firing squad if you attempt to operate on someone with atelectasia, but I do think that it's widely believed to be a much more formidable and challenging cause of trigeminal neuralgia. And there is a general widespread culture, I think, of reluctance to tackle it. It isn't impossible, and I've come across people using sling techniques to try and hold the vessel away. But it's undoubtedly, I think, a more challenging area that's probably best left to people who are quite familiar with it, got some experience with it. So I don't think it's perhaps quite so rigid as that, but that would be my answer. I think it's rarely done. I have limited experience with it. I've only seen it on a very small number of occasions.
Right. Thank you very much. What a lecture it was. It was a lot of piece of information in it and could definitely benefit all the young neurosurgeons who are going to watch this live. Thank you, Professor K. Kiturel and Professor Suresh Nair for the wonderful comments. Please stay back with us. And for the next lecture, I would like to invite the chair, Professor Shubin, to give his introduction remarks.
Okay, thank you, Dr. Dalton and K. Kiturel. So now let's give the time to my younger colleague, Hong Tao. He has come from Xuanwu Hospital, and he is a very young rising star in Chinese neurosurgical field. And he is a youth vice chairman of the neurointerventional branch of the Chinese Stroke Association. And he is also a hybrid neurosurgeon, both doing the open surgery and the interventional treatment. So today his topic is about the resection of brain AVM. Okay, Dr. Hong Tao.
Thank you very much, Dr. Xu. Thanks for your introduction, and I'm very delighted to be here, and thank you for inviting me to present something about the cerebral AVMs. As Dr. Xu said, I both do open surgeries and endovascular treatment. But for the cerebral AVM, it's always a very challenging situation, no matter as open surgery, open neurosurgeon, and but also for the neuroradiologist. So today, because of the time limitation, I will do it very quickly. This is a sentence I like very much. It shows the situation of the AVM resection. He said that the AVM, the aneurysm surgery is a dance and as an elegant art, but in contrast, the AVM surgery is a battle. So when you are walking in our operating theater and you're facing a guy who's very delighted and very after a surgery, it may be it's an aneurysm surgery, but the one who after the AVMs are always very tired and depressed. So it shows that the AVM surgery is always very long and very challenging and full of risks. So I would like to present it with our case series, because in Xuanwu Hospital in Beijing, it's a very large center who focus on the cerebral vascular diseases. And so we have quite huge number of the cases of the aneurysm of the AVMs. And so many of the concepts are from Dr. Lawton's 7 AVMs, the very nice book. So I follow his concept and use my own cases and videos to show that. So we can divide our AVM resection into like 8 steps. The first is the exposure. We always think that the AVM is like the nidus. It's like actually different, and we always sometimes we're lucky because the one visit is is free, and you can see it from the surface of the brain, but sometimes it's very deep in the serous fissure or something like that. So always imagine that you are, as the image shows, that you are you have 7 facets, and so when you are doing the exposure, you want to expose one or even more free surface. Like, for example, like in this case, it's I think it's a middle temporal gyrus. So this is superior, this middle. So we will not go into the pile anatomy, but we will do the arachnoid anatomy to use the free surface between the superior and the middle temporal gyrus, which give you 2 more free surface of this nidus to accelerate, to speed up your resection process. So the second one is very important. It's subarachnoid dissection. It means that like this image shows, I will always dissect the subarachnoid membrane around the nidus. For example, like this case, you cannot see the nidus from the surface of the brain. So you have to do extensive separation of the arachnoid membrane. From this, you can study the angioarchitecture under the microscope, and at this time, it's a translation of the angiographic anatomy before the surgery and onto the surgical field. So during this, you know which is the feeding artery, which is the main feeder, which is the secondary feeder, and this is the one that has been preoperatively embolized. So then you know something about the nidus, where it is. And the third thing is to defining the draining vein. It's very important. I also made some mistake in the first several cases. For example, when you are opening the dural, sometimes you cut the main drainage vein, which is a disaster. You spend 1 or 2 hours to stop the bleeding, but at the same time you have to keep the main feeders compact. So so defining the drainage vein is very important. And also, sometimes you can only see the draining vein at first, but it will guide you to the nidus. So from the draining vein, you carefully dissect it around it, and you can find the nidus. And the draining vein visually illustrated the progress of the resection. For example, this is beginning. At the beginning of the surgery, you can see the color, and this is near the end of the nidus resection. You can see that it turns to be dark. And another thing is the secondary draining vein. We always say that you have to keep the draining vein to the end before you finish the dissection, before you finish the resection of the whole nidus. But sometimes the secondary draining vein, after you have obliterated some feeders, you can cut it, because sometimes the secondary draining vein prevents you from extensively exposing the nidus, which will prevent you from do thoroughly a resection, and it takes a longer time. So sometimes you can cut it, you can obliterate it, while you have to keep the main feeders there. So the fourth step is defining the feeding artery. So we always do the pre-operative embolization for large AVMs. So it's always debating in conferences in China and also around the world. That is, do we need a preoperative embolization? Is it always feasible to the surgery, or sometimes it's more difficult when you are doing the surgery? For me, because I both doing the embolization and the open surgery, I think the answer is yes. I will always doing the pre-operative embolization, but it's totally different for the pre-operative embolization and the curative embolization. For example, if you want to cure the nidus through the embolization, you will inject the glue into the nidus. But for the preoperative embolization, from this image, you can see that the glue is at the arterial end. You will use the embolization as a clip to clip the feeding arteries. You want to clip before you start the open surgery. For example, the deep feeder. For example, the macrovascular. So you don't want to put too much glue into the nidus because it will cause the nidus to be very thick and give very little space for you to dissect them. And after these preparation work, you will start to do the pile resection and the parenchymal dissection. It's a real battle begins, and you are always you always don't want to cut into the nidus because it will cause very extensive bleeding, which is quite hard. I will give you some cases afterward. So at this stage, I always do a circum dissection. You don't want to go deep in one facet too much. So you always do a circum dissection, and you always establish the separation plane before the malformation in the brain. So I always discuss with several neurosurgeons, and they have different opinion. Sometimes they say we always ideally we want to keep dissect the nidus just at the margin of it. That is, one side is white, one side is red. Red is the nidus, white is the brain. But sometimes it will cost you more time to finish the dissection if it's white and red. So from my personal opinion, in non-function area, I will go a little bit further, like 5 millimeters away. So between the white and white, to keep away from the nidus, and you will do it in a much quicker way and save the time because for the large AVMs, it always take like one whole day from morning till night to finish one surgery. So So for another technique is the click first and coagulation, because always we will meet some vessels, so we call it like the desperate vessel, because very high flow there. When you would do a bipolar coagulation, and the heat was taken away by the very high flow, and so you always find it's very difficult to coagulate the vessel. So you put a clip there. It's an AVM, it's an aneurysm clip or AVM clip to stop the blood flow and then coagulate. It will be a very efficient way to coagulate the desperate vessels in this way. So after that, you move to the deep dissection. It's the most challenging part of the renal resection, because it's always deep perforating arteries, and you can see that this is one example of the advantages and the disadvantages of the embolization. For example, for this one, the nidus can be pressed very easily if it's very soft. So it means that if you do too much pre-embolization, preoperative embolization, too much glue into this nidus, it can not be like this soft, which the deep side dissection will be very difficult, because very little space and you cannot see it directly, and you know that there's always a desperate vessel there, and because it's always choroidal artery supply and perforating arteries, and it's very hard to coagulate, and also because it's deep inside, also it's very difficult to use the clip and coagulate technique. And for this video, it's another case, because I want to show it's partially embolized feeder. It's a feeder, but it's very stiff, and you can see that it's gluing there, and the bipolar can see that it's glued there, so the bipolar cannot coagulate this vessel very efficiently, and so in this situation you will need a sponge. So I will put, you can see the bipolar cannot deal with this. So at this time, you will need a I'm trying to go quicker. You would need a gelatin sponge to put it into the glue, because the glue is not always the glue is like it has space in it, so the blood will go from these spaces. So you will need a gelatin sponge to fill in the space and to stop the bleeding, and then you can coagulate this kind of very desperate vessel. So it also tells us that appropriate pre-operative embolization give help to the neurosurgeons, but for inappropriate embolization, it's totally a disaster. It will make the open surgery even harder. I cannot find that part. Find that part that I put a gelatin sponge in it. So this is a video showing that another common situation we were always facing after we dissect, after the dissection. We're always down, we're nearly down, but after the dissection, you can see that it always have bleeding deep inside. Now we know that it's probably because we are not fully finished. We're not totally removed all the nidus. It has some residue. You can see that this is nidus, but after that, you can see that we still have bleeding. We now know that it has some residue near the ventricle. So at this time, cannot just use some cotton to pressing on it. You have to continue dissection. You have to continue dissection. After you're dissecting all these residues, the bleeding will stop automatically. Put a drainage in the ventricle. So the last step is the resection. So you finish resection, but you still have to facing some situation that you don't always want to face. Lesson one is never try to stop AVM bleeding by pressing a cotton on it. Because it's always a very long battle. So I have a dinner and the rest, and my colleague who was on the replacing me for 1 hour, and he has putting some cotton because there's multiple bleeding, and he putting some cotton. He has put some cotton in it to trying to stop the bleed, but actually it's no use, and it causes a disaster, because when you are when you're trying to remove the cotton, it's like resecting another nidus, and now you know that it should be something wrong, because the brain is in edema, and it's outing, and there's bleeding everywhere. The brain is in a very angry situation. You know that it should be something wrong. It has intracavity hemorrhage. So that is the situation afterward. You can see that the hematoma is going out, and so in this case, I have done it in 26 hours to finish this, because you know that it's bleeding inside, the nidus still there. So in this situation, because we're in a hybrid theater, we turn into embolization to quickly embolize the main feeders to stop the bleeding, to lower the pressure, to minimizing the blood into the nidus, and then starting to resect again. So finally, we have finished it and evacuated all the hematoma. From these 8 steps, it's a typical, after this, it's a typical case to show what we're handling the AVM right now in our center. It's a male 26-year-old in lots of contrast aphasia, epilepsy, and there's hematoma. And so I'll go very quick. And hematoma there, and it's a frontal AVM, and have some feeders from the ACA, main feeders from the MCA. And for the location of the nidus, we use some multidiscipline technique. We have done one stage of the pre-embolization to embolize the feeders from the ACA. And we use the DSA reconstruction to show all the feeders, to show the drainage vein, the nidus, and we will reconstruct it with the MRI image, and to show where is the language area and with the precentral gyrus, and there's some arcuate tract. So we also reconstructed the hematoma from the MRI. We know why the patient present with aphasia, because the hematoma is low, so it's close to the arcuate tract after reconstruction. So the patient when have the onset of the aphasia, although the nidus is not in the language area. The nidus is actually in the middle frontal gyrus at the posterior middle frontal gyrus. It's a writing area, so we'll have some symptoms after the resection. This is we use navigation, and we always have a very large opening, because for the AVM resection, we never pursuing minimal invasive. So this is the video. This is the midline, lateral, frontal, posterior. So actually, it's a middle frontal gyrus, posterior part, and they still have some space between the posterior frontal and to the midline front and midline gyrus and the precentral. And then we find the main drainage vein here, and here's part of the embolized feeding arteries. So the main feeding arteries have already finished, because we first from to cutting the main feeders from the MCA. This is the embolized feeders from ACA, and then we start to resect it. Because this vein, we can see that it's still have a very normal drainage function, so we want to keep it patent. And we start the margin of the nidus is here, so we'll keep this drainage vein patent and resect the nidus doing a circumresection. After that, it's down, but still we can see that it's still red. It's still red in this draining vein. According to our experience, it should be some residue. but it's very, on your case, it's already to the cerebral fistula. So we have done, this is intraoperative MEP and SCP monitoring. We have done intraoperative DSA. We cannot see the ratio, so we believe that it's very microvascular in the cerebral fistula, which is asymptomatic, and we don't want to do it at this stage because it's not in the surgical field. So after the resection, the patient is totally normal. The muscle strength is totally normal, but when we let the patient writing some Chinese characters, he cannot write very complex one. So it means that the nidus location was has some influence on the writing function, but we believe that the patient will get recovered. So we're almost finished this this lecture. As a small conclusion, the small AVM and large AVM are two kinds of operation. The small AVM is still quite easy one, but the large AVM sometimes is a battle. And so for large one, because I'm always doing a very tough case, so take a break. And if you are only if you are the only one, but so nowadays we always find another neurosurgeon to take place to let myself have a rest. So with the increase of experience, the indication with the surgery become more and more strict, which is different from the aneurysm surgery. A more experienced neurosurgeon on aneurysm, he tries to deal with the more complex aneurysm, but for the AVM resection, you know that some kinds of AVM cannot be resected. So AVM is still a mystery. Still 1 or 2 minutes left. I will show some progress in the basic science of the AVM. Just it's still mystery. No matter resection, embolization, or SRS, it's still nearly half of the AVM cannot be completely operated. So we are facing, we're trying to find more efficient cure method. New England Journal, as we know that Dr. Ivan Ranovarovic first reported KRAS mutation, somatic mutation in AVMs. And also, we have also published a similar article to find the KRAS BRAF somatic mutation have a very high prevalence in brain and spinal cord AVMs. What does it mean? It means that the genetic mechanism of the AVM, no matter it's cerebral or spinal AVM, are controlled by one single pathway, that is KRAS, BRAF, and MEPK pathway. Somatic mutation can explain nearly 90% of the AVMs. However, this pathway is quite a very, very popular pathway in tumor treatment. We have numerous medications on the way to inhibit the KRAS, the BRAF, and MEPK. So perhaps in the future, we can use the medication to cure the AVM, to make it as neurological disease that do not need to be treated surgically. Thank you very much, and thank you again for inviting me.
Okay, thank you, Hong Tao, for your very informative lecture. So finally, you mentioned some gene, maybe some potential gene therapy for the AVM. So actually, this target gene may be very closely interacted with angiogenesis. So do you have some concern about if you treat, because the AVM is a very local lesion. So when you treat with the medication, so do you worry about the drug, maybe interference with the normal angiogenesis for the other part of the body?
Yeah, it's a very very good question, and always a very very important question. Actually, we're doing some animal study, and now we are finding some way which is not treating the angiogenesis, but we're targeting on the parasite. The parasite, the AVM, why it's easy to bleeding, because it's not the normal vessel. We have endothelial cell, but we have irregular parasites to surround the endothelial cell, to make the vessel to be very fragile, to easy to bleeding. So we find that these medications do not target on the endothelium, but on the parasite, to call for the parasite to surround these irregular vessels, to make more parasites to surround it, to make the vessel to be more strong and less and to be less probably to bleed. So I think that's a very wise and maybe a very promising treatment target for the medication development.
I think actually the AVM bleeding cause is very complicated. Actually, we can find some spontaneous thrombus in the main drain vein, so that can cause dramatic hemodynamic change in the nidus. So this can cause the bleeding of the nidus.
Yes.
So I want to ask some comments from Trigeminal. Please unmute yourself.
I'm wondering if you would be doing embolization. What is your indication for embolization in AVM surgery?
Thank you, Dr. Turiel. It's a very important question. As I mentioned in the lecture, we always have debates and on the preoperative embolization. Now, for me, I only do embolization for first, if I could embolize the deep feeding artery, which is very hard to deal with during the operation, I will embolize it. And second, for the microvascular, because very large fistula will cause the post operative complication, the hematoma, because it's very huge dynamic change. So if I can embolize it preoperatively, I will do the embolize. So the deep feeders and the microvascular.
You know, it is always a question in my mind. How much is the value of embolization? Because we have no way to compare what would this operation be if it was not embolized, and what would it be if it was already embolized. There's no way to compare pre and post-op, pre and post embolization status. So it always wonders, because embolization, in my personal opinion, has made very little impact on the outcome of the surgery or even the difficulty of surgery. AVM, if it will bleed anyway. So I still don't know the exact answer. What does Dr. Binshu say? What is your opinion?
Yes, I agree with you. Actually, Dr. Hongtao also mentioned that sometimes it makes even more difficult when you embolize and make the nidus even harder, and it's even harder to hemostasis during the operation.
Yes.
Yes.
Exactly.
It's always a debating, and
yes.
Yes, but if you, I think it can give you more confidence. Maybe this is an advantage.
Psychological.
Yeah. Yeah.
Definitely.
Yes, because you know, if you are a young neurosurgeon, maybe you want to pre-embolize it. Yeah. If you are very experienced neurosurgeon, you may don't think so. And Dr. Hongtao, I will ask you a question. I noticed that you treat some very some AVM at the acute stage. So is this normal for in your hospital to treat it directly in the acute stage after the hemorrhage?
Yeah, that's a very, very important question. Actually, in our center, we are very hesitant to do the AVM resection in acute stage, because the brain after the hematoma, the brain is in a very angry stage. You will find that the white matter has bleeding everywhere, and it takes longer time for you to stop the bleeding. And so if we can evacuate the hematoma, and while keep the nidus still silent, and we will close and leave the patient for like 1 month after, when they recover and then the brain have returned to a normal stage, and then do the nidus resection. But however, in some cases you don't have the chance to do it. The nidus is always bleeding, so we have to do a total resection, and at the same do the evacuation of the head.
Yeah, I noticed you when you resect the AVM nidus, you normally cut through the border of the AVM, between the border of the AVM and the normal brain tissues. So is this in every case? Because not sometimes if it's in the
functional area,
uneroguant field, actually you can do some more resection. Yeah. It may make the resection procedure faster.
Yeah, that's it. That's as I mentioned. Sometimes it's in non-functional area. I will do white, and in functional area, for example, pre-central gyrus, I will do white red to strictly follow the margin of the nidus. But in like the middle, the anterior parts of the middle frontal gyrus, I will do it further.
Yeah, it's have a term of a cat surrounding the hot pot.
Yeah, that's it.
Right.
Because there is always secondary ectasia around the nidus, so it's hard if you strictly follow the mark.
Okay, thank you very much for the very informative presentation, especially for the research work. Thank you again.
Thank you. Thank you, everyone.
Thank you very much, Professor Hong Tao. That was a wonderful lecture. We'll take one comment from Dr. Liu Bun Seng, my co-host.
Thank you, Raja. Thank you, Professor Hong Tao. I have just two questions for you, Prof. In pre-op embolization, what do you think the embolic material is the best use so it's more friendlier to a surgeon to control, either histoacrylic or onyx? And my second question to you is, we actually put same weightage for reason not to operate between iliacone brain area and also deep drainage. And in my center, usually iliacone area are most important, where we try not to do, especially those without neurological deficit. So what do you think that the current SM classification, do you still follow the scoring and give the same result in your practice, or do you have certain preference on different category of condition? Thank you, Professor.
Thank you. I can ask the first question, and we always use the glue. We have glue, which is one kind of thing analog of the NDCA. We never use the onyx because the onyx is not very friendly to the open neurosurgeons. Because as I showed during my lecture, it's like it will cause a partial embolized vessel, which is the last. That is onyx.
Okay. How about the do you place the same weightage between iliacone brain area and deep brain drainage for not doing surgery in certain cases? Thank you, Professor.
Yes, we quite strictly follow the specimen marking grade. For the specimen marking grades 4 and 5, we seldomly do the open surgery. We will do like 1 or 2 stages of the embolization, then the SRS, or sometimes we will do SRS. After that, we will do the open surgery to downgrade the specimen marking grade, to turning a specimen marking grade 4 to a specimen marking grade 3, and then we can resect it. What's one point that I have resected several AVMs after the SRS, which we are very delighted to find that the SRS can help the open neurosurgeons because it makes the resection to be easier, because it has obliterated many vessel feeders, which is very hard for neurosurgeons to deal with.
Right. Thank you very much. We have Professor Dalton still with us. He himself is a cerebrovascular expert. Any comments from Professor Dalton? Professor Dalton?
I congratulate you on your presentation. It was very interesting and informative, and I appreciate all the videos you showed. I think we have a similar approach to you. We have a lot of pre-operative interventional neuroradiologists. I wouldn't say it was, every caseization, but we have a lot of back and forth about the safety of preoperative embolization. And generally, as provided the radiologists do feel that it is safe, they would proceed with it. We have had a few cases where the feeders were very distal and catheters have been stuck, or they've had, AVM rupture as a result of aggressive embolization. So that's something we're a little bit cautious of, but a lot of our cases get embolized preoperatively also. I don't profess to have as a large an AVM practice yet at my stage of my career, and I actually found your presentation very, very informative and interesting. So thank you very much.
Thank you.
Thank you very much. I think it's time that we wind this webinar for today. Any closing comments from Professor Shubin?
Okay, so today it's also a very successful webinar. Today's WeChat channel audience it's around 1,000. Yeah,
right.
It's quite good. Yeah.
Crowd.
Now the accumulated audience for this whole series of the webinar is now around is more than 70,000.
It is great achievement.
Great.
Thank you very much, Professor
Mhm.
Shubin. It wouldn't have been possible without you. We are really indebted to you. So I think it's time for winding up. Professor Turel, would you like to say something?
Thank you.
Thank you. Thank you very much. So I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to sincerely thank both the speakers for today, Professor Arthur Dalton and Professor Hong Tao, for their beautiful lectures and teaching the young neurosurgeons about their respective subspecialties. Thank you both the chairs, Professor K.K. Turel and Professor Shubin, for sharing the wonderful words of wisdoms from them. Thank you, my dear co-host Liu Bun Seng and all the distinguished faculties, Professor Hidehito Kumura, Professor Suresh Nair sir, and all the other, Professor Takashi Kon and all the other distinguished dignitaries who have joined us. I would like to mention a special word of thanks to Professor Nigel Mendoza and Professor Ramesh Nair for their support for this webinars and recommending Professor Arthur Dalton. Thank you so much. Until we all meet on next Wednesday, it is bye-bye from all of us. Thank you very much for joining.